PCL. Okay, now how many of you do or has treated acute knee dislocation? How many of you? 2, 3, 4, 5. So if you have such patient, injury is young, has dashboard injury and presented to ER with this, what do you think the diagnosis? It's a dashboard injury. PCL injury. Patella fracture, excellent. So it could be a patella fracture with posterior knee dislocation. Now, if you see dashboard injuries, what do you think about? Hip, excellent, associated injury. So always when we have high energy, trauma, posterior knee dislocation, dashboard injury, we have to think of associated hip injury like femur neck fracture and cerebral acetabular fracture. So here, vascular, excellent, and we'll come to that. So here the X-ray, there is posterior fracture dislocation. Now, if you want to manage this patient, we have many questions. The first, do we need to do CT angio or arteriography to rule out vascular injury, which is common in knee dislocation? Do we need to do early surgery or delayed surgery, one-stage surgery or two-stage surgery? Yeah, let's try to do ligament repair, reconstruction, or augmented repair, to put knee brace or external fixator or hinged external fixator or cervical frame. All these questions, I think we have to answer all these questions and to show how we can manage this in the term of modern evidence-based practice, and also how to avoid missing associated injuries, either knee injuries or associated hip injury or vascular injury. Now, knee dislocation is fortunately rare but serious injury, and it's often reduced spontaneously, so it can be missed. Yeah, that's right. So we have to think of that. Neurovascular injury are common, up to 40% of cases. We have high energy and low energy knee dislocation. The low energy, the high energy associated more with the neurovascular injury. And the low energy happen in which type of group of patients? Especially in women and morbidly obese patients. And furthermore, we have what we call it ultra low energy knee dislocation. And this happens in morbidly obese patients. So if you face a knee injury in the ER, in a patient who is morbidly obese, you have to think of knee dislocation, even if trivial injury. Now we have two classifications. One, which is the Kennedy classification of all the direction, where is the T in relation to the femur. And the second, which is more applicable, is the Schenck classification, which is related to the pathoanatomy, the type of ligament injury. Now, this is the Kennedy. We have anterior, posterior, medial, lateral, and rotatory dislocation. Regarding the anterior one, what's the mechanism? What do you think? The anterior, mostly hyperextension. So the first ligament to rupture is the ACL. And what's important with this type of fracture is, dislocation is, popliteal artery intimal injury, which can be missed initially. So we have to think of that seriously when we face anterior knee dislocation. The posterior one, we have the first rupture is the PCL, and it's associated more with complete popliteal artery injury. We have the medial lateral, less common. The lateral is more common than medial, and it's more associated with the neurovascular injury, and especially peroneal nerve or peroneal nerve injury. The medial side is more associated with posterolateral column. The fifth type is the rotatory, and this is very important because they are mostly irreducible. Cannot reduce in the ER because of what we call buttonholing. Yeah, exactly, the femoral condyle within the capsule. So if you try to reduce an injury and it's irreducible, don't try a lot before you make sure that this is not rotatory instability. And the posterolateral is most common rotation. And here, if you see, you can face this, what we call dimpling, And this means that the capsule is tethered in the notch, and there's buttonholing with the femoral condyle. So what makes the Kennedy classification not applicable is that spontaneous reduction. So you fit the patient, make an X-ray, then he is there. So how you know that this is anterior, posterior, or whatever? And the second thing, that because of spontaneous reduction, we can even miss the diagnosis, and so we have to think of indirect signs or associated fractures that if we see it, we have to think that there is possible multi-ligament injury or dislocation. Of these, finding widening joint space. I think we have discussed that in the discussion group. And associated fractures like fibular head fracture, or epicondylar fracture, or tibial eminence fracture, or tibial plateau fracture. So if we see these, even if it looks simple fracture injury, we have to rule out that there was knee dislocation and multi-ligament knee injury. Another sign, what's called this, Victor? What we call this sign? This is the Segon, which indicate a bulging of the capsule of the deep meniscofemoral ligament. And this is innocent looking sign, but it's not. The Shin classification, which is being called patho-anatomy. So which ligament is ruptured, and this is depend on the clinical finding and the MRI finding. And this simply, we have 4 types or 5 types. Type 1, when there is single cruciate, but you may have with it medial collateral or lateral collateral, but the first thing is it one cruciate or not? So if it's 1, this is type 1, whatever you have associated injuries. If 2, this is just the cruciate ligament injury, this is type 2, and this is rare to have only cruciate ligament. And 3, in which we have 1 cruciate ligament and 2 cruciate ligament and 1 collateral. So if it's lateral, so it is 3L, and if it's medial, 3M. In the 4, when we have 4 ligaments, and what's the importance that the neurovascular injury is more common with type 4 and 3, and 3 lateral. This is even more common than the type 4. So if you see this, you have to think of associated neurovascular injury. Regarding the 5, when there is associated fractures, and we go classification accordingly. And when there is vascular injury, we say C, and when there is nerve injury, we add N. So neurovascular, more common, as I mentioned, in type 3L and type 4. Associated injuries like fracture, up to 60% of cases, and associated soft tissue injury, periarticular avulsion of the capsule, not only the ligament, of the capsular structures, of the tendons, and also of the muscles, so, and displayed menisci. So if you see this, what do you think, which tendon is ruptured? Which tendon? If you have this vessel dislocation. Patellar tendon. So you may have patellar tendon avulsion, you may have quadriceps tendon, sometimes the biceps tendon. I'll show you a case where biceps tendon was avulsed. So you have to rule out these associated injury fractures. Now the question, is it real that we can miss a knee dislocation, this major event? Can we miss it? Yes, this is a case referred to me to do ACL reconstruction. The patient has, before 4 years, have a major injury, رافع شوكية واقع على رجله. At that time he had all these injury, femur fracture, which was fixed by X-fix and then plating, neurovascular injury, has peroneal nerve injury, and popliteal artery injury, which was grafted, and soft tissue flaps, and so on. All these injury, and the surgeon did not think of dislocation. So if you see here, there is a rotatory dislocation. You see the medial condyle is dislocated, the lateral is in contact, but subluxed. And if you see the CT, it seems that the posterolateral corner acts as a pivot of rotation. So all the knee, the tibia is dislocated anterolateral. And you see it's clear here by the 3D CT. So why it was missed? Because no one think about it. And the second, don't accept improper X-ray. Well, by discussion group, one of our colleagues said, this is not proper X-ray. Excellent. This is not proper. I don't accept. You have to have proper lateral view X-ray. and you should have the index of suspicion. Now, patellar fracture, we don't know the true incidence, the incidence of this associated with knee dislocation, but what's the importance? That if you have patellar fracture, you may miss knee dislocation. You just think about the patellar fracture and don't look for a knee dislocation. And this is important. Whenever you have patellar fracture, ask about the mechanism of injury. Is it high energy trauma? So if it's high energy trauma, you have to rule out knee dislocation or associated fractures, as we mentioned, hip fracture. So mechanism of injury should be taken details about the energy of the trauma, also index of suspicion, and proper reading of the radiograph. And if you are in doubt, you can do MRI. Look here, what you can see. Subluxed, there is posterior subluxation, yeah, is it right? So you have to think that this is part of fracture dislocation. Now regarding the management, back to our case. Who would do CT angio for this? Okay, so what literature tells us that it is not necessary. You don't need to do CT angio or arteriography for each patient. Evidence tells us that it is unnecessary when your examination, physical examination, the pulses and the ankle brachial index is normal, you don't need to do CT. But if you are in doubt, there is diminished pulses or decrease the ankle brachial, you have to do it. Because if you don't do it and go far to expiration, you may are going to overtreat. So لما بتعمل السي تي انجيو ممكن انه يخليك ما تعمل unnecessary surgery. But in cases when you have no pulses, so you have to go for exploration, surgical exploration. After reduction, if still no pulses, you go for exploration, and intra-op you may do CT, you may do arteriography. So early studies show that Doppler is enough with physical examination to rule out significant injury, and this is the approach we have discussed. Normal, so no need, but do Doppler before any surgery. Peripheral diminished, so we do arteriography, and it's blocked, no pulses, so we have to go for urgent surgical exploration. Now, to do early or delayed treatment. Who would do patellar fixation and then after that go for a staged reconstruction procedure? Anyone of you? Who would do early surgery? Who would do delayed surgery? Now, what literature tells us, and this is systemic review, that early surgery provides much better clinical outcome than non-operative or delayed surgery. So we have to go for early surgery, not more than 2 to 3 weeks. And also, if you want to do immediate surgery, you carry the risk of arthrophyrosis, so you should do it only in selective cases, immediate. But delayed surgery within 2 weeks is the most appropriate option. Now, the second question, to do 1 stage or 2 stage, to do ligament repair, augmented repair, or reconstruction. What literature tells us that no ideal treatment, but reconstruction showed better result than just repair. And delayed ACL reconstruction may prevent or decrease the incidence of arthrophyrosis. So like, if it's tell us that to do reconstruction and to do staged procedure, yes, it's right? Yeah. I don't accept. Okay, 1 or 2 stage, no convincing evidence, so you can do 1 or 2 stage procedure. Each case should be individualized. So you may have simple procedure, like you can do everything in short time, soft tissue condition is okay, no associated fracture, and so on, you can do 1 stage. Soft tissue, the patient situation, or soft tissue problem, so you can stage procedure. So each case should be individualized. Now, the second question, do we need really to reconstruct the ligament? Okay. What literature tells us that there are many reattachable lesions during the operation. This is a prospective study on 63 cases, and they showed that there is high incidence of reattachable soft tissue injuries during the operation. And with repair, they have good results. Now, the question, how we can reconstruct this complex tissue? This slide from one of my lectures. أنا والدكتور زياد كنا في multi ligament cadaver course في عمان قبل 3 شهور. زياد حكى عن إنه كيف how we would reconstruct all these complex structures by just simple lateral reconstruction. And be the same, how we can reconstruct. Suppose that you have avulsion of this capsular injury. Is it enough to do just reconstruction of this ligament? So we have to think a lot about repairable tissue. But again, the question, why to reconstruct and what's the risk of repair? Because if we do repair, we have risk of failure, tension on the suture side, repair side, and failure. But what about augmented repair? Do you know what's augmented repair? Augmented repair, that you make the repair side, and after repair, you bridge the repair with either a graft, autograft or allograft, or you bridge it with a synthetic material like fiber tape. So when we put a fiber tape, any tension on the suture side, it will go to the brace. So it's called internal bracing. So with this advancement of the technique, repair is possible, and not only possible, even with ACL and VCL injuries, transosseous augmented repair yields good and excellent results. And the same for other multi-ligament injury, you can reattach safely with good functional stability after the operation. Now, how you do augmented repair? This is an MCL injury. You see, you fix the suture material proximal. After doing the repair, you pass it, and then after that, you fix it with knotless anchor. So you have your suture material bridging the torn ligament. This is another case. This case, patient is football player, had knee dislocation, and this avulsion injury of all the lateral complex ligament with the biceps tendon. So what I did repair and augment the repair with the autograft. Because literature tells us that only repair on the lateral side provide high revision rate. So it's better here to augment, and preferably with graft. Now, the other question, to use X-Fix or brace. Cast or PAC slab should not be used because there's problem of the soft tissue care, and the bandage, and the vascularity, and the diagnosis of compartment, and so on. So you can use brace and look at in extension before the operation, but you have to have serial X-ray imaging, because if the joint is subluxed and the reduction is not maintained, you have to apply external fixator till the definite surgery. And when using external fixator, we have either spanning fixator or hinged fixator. Spanning should be used only for limited time. Don't immobilize the knee. You have to mobilize the knee early. So hinged external fixator is more preferable, and it helps to regain motion, to start early motion, and it has certain indication, not all, in all cases. Post-operatively, again, we use most of the time a brace, not external fixator. But you face some situations that the brace is not enough, like in morbidly obese patients, how brace will function, soft tissue injury, and so on. So in these situations where you have highly unstable knee, morbidly obese patient, vascular or soft tissue injury, or in severe polytrauma patient when you need damage control surgery. So in these cases, external fixator is preferable, and it's much better than using a brace. Now, hinged external fixator, hinged circular frame or Elizarov, we don't have much data in the literature, only a few case reports. It provides more stable construct, it can be adjusted, and it's mostly used for chronic cases, which is also rare cases. This is my patient who present late after reduction and doing the job. I did a circular frame to maintain the reduction, you see, to maintain the reduction and to protect the repair and reconstructed ligament. And at the same time, it provides us with early range of motion. And you see here, after 4 months, 3 to 4 months on removal of the Elizarov, the knee flexion is up to 90 degrees. So it's preferable in this situation. Now, back to our patient. The first step, reduction was very unstable. I reduced myself, was unstable. The first is to rule out associated injury. Yeah, the strike, this is critical. And to do CT angio or not, who would do? Look, he has left ankle injury, so we cannot check the pulses and the ankle brachial index. So to do or not? To do, and we did it, it was normal. Now, to do immediate surgery or late surgery. The knee is unstable, we have patellar fracture. So I decided to go direct surgery immediate, the second day, because of the patellar fracture. And we found this, all the capsular tissue and ligament avulsed. So to do repair or reconstruction? Augmented repair, who agrees? Augmented repair. And this is what I have done. Augmented repair of the collateral ligament here, and repair of the capsular, avulsed capsular structure. Augmented repair for the ACL. You see here the ACL suture passing, and it passes through transosseous tunnel. Here, you see. And before we pass the suture, everything, but before we tighten it, we make the PCL. The PCL was unfortunately irreparable, not ideal for repair. We did some stitches and bought a synthetic material, which is 3 fiber tape passed through this tunnel. This tunnel, and look, we provide reduction of the joint because the joint was not stable. We fix it to its original attachment and fix it with screws. So this is one stage procedure for this complex injury. What's important, we fear of what? Arthrophyprosis. So you have to control this early motion by yourself. Okay? You have to show the patient how to do it, assisted by the other leg. You make sure that he's moving, otherwise you may end with a stiff knee. And here the X-ray after 6 months, you see there is some posterior subluxation, but the patient is functionally good. These screws which was used to fix the sutures. Here the stability on the medial and lateral side was excellent. The range of motion is good. But when you do Lachman and posterior Lachman, you see there's some laxity of the posterior cruciate ligament, but with end point. So the patient was asymptomatic and he went back to his daily life activities, and we don't want to do any further ligament reconstruction, etc. So back to our algorithm, if you think to treat knee dislocation, please, before doing any surgery, make sure that the joint is maintained in the reduced position. In all algorithms, it mentioned that you have to keep maintaining the joint before doing the ligament surgery. So by conclusion, knee dislocation often reduced, so you don't have to miss it. Associated fractures or injuries are common, don't miss it. Early surgery provides better outcomes than non-operative and late surgery. And immediate surgery only exceptional because of the risk of arthrophyprosis. Knee brace is enough in most cases, pre and post-op, but we still have rule for external fixator in certain situations like very unstable knee or soft tissue injury or morbid obesity. Hinge circle frame, rarely used, but maybe in chronic cases. Augmented ligament repair, please remember that. Augmented ligament repair is very attractive option with good promising result. Delaying ligament reconstruction is an option, and you can do a 2-stage procedure. And early post-op rehabilitation is essential. Please don't immobilize the knee. Thank you.